Onc Live Insights is a video editorial program produced by Onc Live.
Regarding third-line therapy after a patient's already had prior bortezomib and lenalidomide, I think there are several different options in that setting. I think certainly bortezomib retreatment is an important option in those patients, and there's, I think, a certain degree of comfort that comes for patients when using prior systemic therapy they've already had. So they're comfortable with bortezomib, they're comfortable with side effects and how it's administered, and so I think there's a certain kind of a comfort that comes with using bortezomib that's difficult to describe, but I think that patients often feel comfortable knowing that there's not a new learning curve with trying to use something that they've prior received. Other options in that setting also include pomalidomide-based therapy, carfilzomib-based therapy, and then now with Faradac's approval, the combination of Velcade and panobinostat I think is also an important option in that setting as well. Of course, alkylating therapy is always an option for these patients as well. Regarding third-line therapy, I think it's important to also understand where some of our newer trials and some of our new data fit into the setting as well. And so for somebody who's already had prior bortezomib and lenalidomide and in the third-line therapy, often these patients will already be exposed to bortezomib or lenalidomide. And in that setting, unfortunately, our data with Aspire, where we used carfilzomib Revdex versus Revdex, doesn't apply in this setting because these patients would already be lenalidomide exposed or refractory. The same thing for our current data with Eloquent 2 as well with elotuzumab. And so I think that data is great, but it doesn't really apply in this third-line setting where these patients have already had prior lenalidomide. And so I think really the best data that fits in this setting is either going to be Velcade retreatment, and so there's an indication and approval for that. But I think the other options in this setting also, as I mentioned, is going to be a combination of Velcade and panobinostat, as well as alkylating therapy, as well as carfilzomib and pomalidomide, and other combinations as well.
Now, at the present time in our current clinical practice, the third line of therapy can be retreatment with bortezomib-based combination, retreatment with a lenalidomide dexamethasone-based combination, or due to the recent approval of the second generation immunomodulatory drug pomalidomide, pomalidomide plus low-dose dex can be an optimal option to be used in the third line of therapy after lenalidomide-based therapy in second line. What is the problem with this approach? That after bortezomib and lenalidomide, patients are going to receive again an immunomodulatory drug, so the same class drug. And physicians usually try to switch drug class because we feel more comfortable exposing the plasma cells to agents with a different mechanism of action. This is the reason why the third line now in the clinical practice, and at least here in Europe, pomalidomide plus dexamethasone is probably competing with the bortezomib-based combination used as retreatment if the patients previously responded and had a good toxicity profile when they received the bortezomib-based combination in the upfront setting.
Depending on which jurisdiction one works in, there is variability in drug availability. I can use both IMiDs and proteasome inhibitors for relapse disease. But some patients in fairly short order travel through the available therapies, particularly if they've got adverse biology. That's then very challenging as to what to do in patients at, say, second relapse or third line. In younger patients, that's the context in which I might try and reset the disease biology by doing an autologous transplant with high-dose therapy, because then may then provide a platform for the reuse of IMiDs or proteasome inhibitors. I'd be more inclined, however, in the absence of an autograft, again to try and seek access to novel drugs through clinical trials. In elderly patients, the reality is that treatment at third line is uncommon. Not many old patients are treated beyond second line, and there's evidence, real-world evidence, to suggest that. However, in the small numbers that are in that situation, I would be more inclined to adopt a gentle approach, perhaps using more traditional therapies such as alkylating agents and steroids, or the reintroduction of low doses of thalidomide, for example, to try and achieve disease control without engendering too much toxicity. We use a lot of bortezomib. The reality is that we can access it multiple times for retreatment. The way that we deliver bortezomib these days on a weekly subcutaneous schedule is far more tolerable than the early experience with intravenous and bi-weekly. And so there are very few patients who we can't treat based on toxicity. The major consideration for retreatment with bortezomib really is the extent and duration of prior response to the drug. So if I had a patient perhaps who's at a 6-month treatment-free interval and then starts to progress, I would strongly consider retreating with bortezomib at that point in time. The majority of our patients, whether they're young or old, undergo induction therapy with bortezomib. We know that perhaps 75% of patients in Australia get induced with the bortezomib-based combination. So the options at first relapse, for example, would be to retreat with bortezomib or change the class of drug to an IMiD. That may be predicated on prior toxicity considerations or duration of first response to the bortezomib. Subsequently, I think I would like to consider, so for example, at second relapse, the introduction of a different immunomodulatory agent, so the introduction of lenalidomide or pomalidomide, which may work in patients previously exposed to thalidomide. There'd also be the opportunity, I hope in the near future, for example, to introduce further classes of drugs such as panobinostat or possibly later generation proteasome inhibitors in patients with prior bortezomib exposure.